We'll give everyone like a couple more minutes just that people can trickle in. Once we have like about 40, 50 people, we can just get going.
Okay, sounds good.
Thank you. Maybe we can get started. That's okay. Good morning, everyone. Welcome to another cardiovascular medicine grand rounds. Today, we are really honored to have welcome Dr. Lvad here to talk to us about obesity and obesity paradox in cardiovascular disease in 2022. Dr. Lvad attended medical school at LSU Medical College in New Orleans and did his internal medicine training at Ochsner and cardiology at Mayo Clinic. He's currently the professor of medicine and medical director of cardiac rehab and prevention and director of the exercise lab at the John Ochsner Heart and Vascular Institute, Ochsner Clinical School, the University of New England School of Medicine in New Orleans. He has authored over 1,000 medical publications and two cardiology textbooks and serves on 40 editorial boards, including JACC and American Journal of Cardiology, and is the associate editor and cardiovascular section editor of the Mayo Clinic Proceedings. He's also the editor-in-chief of Progress in Cardiovascular Diseases and is the author of the book, The Obesity Paradox. With that, thanks for joining us this morning, and really looking forward to hearing you.
Thanks, Rohan. And one of our fellows, Adrian De Silva de Abreu, just joined in heart failure this past year, and he and I did a number of papers together, so I hope he's doing well. It's a privilege to speak here. I wish I was in New Haven today. I understand y'all have a very warm 30 degrees where we have a freezing 47 degrees here in New Orleans. So I wish I was running in New Haven. But it's a pleasure to speak on one of my favorite topics, obesity and the obesity paradox. I wrote this book, which I don't think is much of a conflict anymore because it's been published since 2014. And I certainly am not getting many royalties now. But I started, as you mentioned, as editor-in-chief of Progress in Cardiovascular Diseases in 2014. And my very first issue was on this topic, and it was so successful. It's been the most highly cited papers in the history of progress in cardiovascular disease that we did it again in 2018. I got a guy from Granada, Spain, Francisco Ortega, to join with me, and we have 18 papers from some of the leaders of the world on this topic, and these are being very heavily cited as well. I was also very privileged that the editor-in-chief of JACC, Valentin Fusta, asked me to lead the healthy weight and obesity prevention article for his JACC Health Promotion Series. I also led the physical activity article in this series, and this has been very, very successful and also been very highly cited. Now, I know everyone's aware of the fact that we're in an epidemic of obesity. 3/4 of adults in the United States are currently either considered overweight or obese. 42% meet the criteria for obesity with BMI over 30 kilogram per meter squared. I think what's even more concerning is that severe class 3 or morbid obesity, that's kind of a mean term, morbid, but BMI over 40 is now present in 9%, 1 of 11 adults in the United States meet this criteria. And obesity is second only to tobacco abuse is the number one cause of preventable death in the United States. There are a number of course, adverse effects of obesity. It certainly increases insulin resistance and leads to glucose intolerance, metabolic syndrome, and type 2 diabetes. It raises blood pressure in everyone and is a considerable contributor to hypertension. We've actually published a lot on the fact that even independent of blood pressure, it leads to abnormalities in left ventricular geometry like concentric remodeling and left ventricular hypertrophy that increase risk. It worsens the lipids, particularly raises the VLDL and the triglycerides, and then lowers the cardioprotective HDL particles. It leads to abnormalities in endothelial function, which is the common denominator in most vascular disease. It leads to abnormalities in both systolic, but particularly diastolic left ventricular function, why it's such a cause of heart failure. It would preserve the ejection fraction because of the fact that the fat cells of the adipocytes produce cytokines, then stimulate the liver to produce things like C-reactive protein and other inflammatory proteins. It's a very pro-inflammatory disease. It's also very prothrombotic. It leads to obstructive sleep apnea and a number of things that affect cardiovascular disease. And if you consider this slide, what excessive adipose tissue does to both the left and the right sides of the heart, it's no big surprise then that not only does it increase the risk of left ventricular failure, but it really significantly increases all of our cardiovascular diseases like hypertension, coronary heart disease, atrial fibrillation, as well as heart failure, particularly with preserved ejection fraction. Now, before getting into the obesity paradox, I think there's a lot of debate of what is the actual cause of obesity. I think most people blame it on the fast food, the sugary beverages, the Coke and the Pepsi, Dr. Pepper, blame it on the fast foods like McDonald's and Burger King and Taco Bell. And this is certainly contributing. But my colleagues and I really believe that the very marked lack of physical activity, which has occurred over many decades, is the fundamental cause. And we published this paper a number of years ago that got a lot of publicity. It wasn't all good publicity. Just for example, it was on Fox News 3 times in one night. I don't think y'all probably watch Fox News too much where in New Haven, but it's on every night in Louisiana. We were on Jay Leno's last monologue, one of his last monologues. There was a picture of me in the news, one of the major newspapers, that had a caption saying, "Women are getting fat because they're not doing enough housework." So you can imagine how that went over. But basically, we studied 45 decades, 50 years of household management energy expenditure in women, a fancy way of saying how much energy they expended doing housework. And not surprising, with industrialization, there's been a marked decline in the amount of housework that women did over 5 decades. In the average, it was more so in the women who were not employed, and less so in the women who were employed. But basically, it averaged about 1,800 less calories per week being burned by women doing housework. And to make up for that, the typical woman today would have to be walking or jogging 18 miles a week to make up for the lack of energy expenditure during housework. Now, we of course didn't study housework in men because men are doing housework now, but they certainly weren't doing a lot of housework 5 decades ago. We did study occupational energy expenditure in both genders and showed very marked declines over time that you would expect. And when you plug this into what's happened to the increased prevalence of obesity, it almost totally tracked the increased prevalence of obesity. So not only is this playing a role in obesity becoming more prevalent, but because of the fact that probably the strongest contributor of cardiorespiratory fitness is physical activity. That's not the only contributor. There is a genetic component of cardiorespiratory fitness, but the strongest contributor is probably physical activity. This is playing a role not only in increasing obesity and weight gain over decades, but it also is decreasing the fitness in our population. There's no question, though, that obesity leads to more cardiovascular disease. This is a big paper by Kahn and JAMA Cardiology in 2018. It analyzed 10 U.S. cohorts with 3.2 million person years of follow-up, and certainly showed an increased cardiovascular disease and cardiovascular disease mortality associated with obesity. And right around the same time in the European Heart Journal, there's a study of nearly 300,000 Caucasian Europeans that showed exactly the same thing. Obesity, particularly abdominal obesity, was associated with more cardiovascular disease and more cardiovascular disease mortality. But I've published a lot over the last 2 decades on the obesity paradox. And what this means is that although obesity is implicated as one of the major risk factors for most cardiovascular diseases, as we've mentioned earlier, hypertension, heart failure, coronary heart disease, atrial fibrillation, evidence from the clinical cohorts, though, of patients with established cardiovascular diseases has indicated an obesity paradox, because individuals with overweight and obesity with these diseases tend to have a more favorable short and long-term prognosis, meaning the person who comes into my office after a myocardial infarction or with heart failure who has a BMI of 22, 2 or 3 decades ago, I would have said they had a much better prognosis than the person who had a BMI of 32, and it's exactly the opposite of that. So what about hypertension? We know that obesity increases the blood pressure. Independent of the blood pressure, it increases concentric remodeling and left ventricular hypertrophy, which worsen prognosis. It increases the cardiometabolic abnormalities in hypertension. But despite this increased prevalence, patients with hypertension and obesity seem to have a more favorable prognosis. And this was very well shown 15 years ago by Uretsky and Mesley and colleagues from the INVEST study, 22,576 patients in this study, despite the fact that the obese had less control of their blood pressure, they had 30% lower mortality, cardiovascular mortality, and almost all of the cardiovascular events were lower in the obese in both the men and the women. Now, many other studies show the same thing. Some show a U-shaped curve where there's a high risk at the low weight and a high risk at the very high weight, but almost all of the studies show lower risk in the overweight and the mild obese with hypertension. So in aggregate, although obesity is a powerful risk factor for hypertension and LVH, patients with hypertension and obesity may paradoxically seem to have a better prognosis, possibly having a lower vascular resistance, a lower plasma renin activity. Now, we reviewed the data several years ago in heart failure, which is probably one of the strongest things that obesity leads to. The Framingham Heart Study, in fact, 2 decades ago, Kincaid and colleagues and 5,881 Framingham participants showed that heart failure increased across the entire spectrum of obesity. Basically, for every 1 kilogram per meter squared increase in BMI, heart failure increased by 5% in the men and by even more, 7% in women. So no question, there's more heart failure with obesity. And we reviewed this in a state-of-the-art paper in the Mayo Clinic Proceedings a couple of years ago. And this actually became the highest cited paper that year in the Mayo Clinic Proceedings. And we've also particularly reviewed this in the heart failure with preserved ejection fraction. But certainly, Pandy and colleagues has published several papers on this showing that heart failure increases by 30% in the overweight and increases by nearly 3-fold in the obese, whereas the same thing happens with fitness. The highly fit have approximately 1/3 of the heart failure as those who are in the lowest fit. Usually the lowest fit are defined as those in the bottom quintile or the bottom quartile of age and gender associated fitness. Physical activity also plays a significant role in preventing heart failure. It probably only does so a little bit in heart failure reduced ejection fraction, but does so significantly in heart failure preserved ejection fraction. In the same way, obesity plays probably just a small role to increase the prevalence in heart failure with reduced ejection fraction, but plays a dramatic role, as most of us realize, in heart failure with preserved ejection fraction. But then once heart failure develops, probably the first major study from this was from UCLA, from Tamara Harwick and Greg Foneroy back in JACC 2 decades ago, of 12,003 heart failure participants, all had systolic heart failure. You can see the average ejection fraction was in the low 20s. And they showed that the best survival was in those who had overweight BMIs, followed very closely by the obese BMI. The worst survival was in the underweight. Almost all the studies show this, followed closely by the normal BMI patients. And in this study, having a higher BMI was an independent predictor of better survival. I was on the PhD dissertation committee years ago from Antigone Aureopolis from Canada. I've actually never met Antigone except on Skype, but she did this paper, and I was not a co-author on this, of 9 observational studies in systolic heart failure of nearly 30,000 patients, showing a strong obesity paradox, more so in the unadjusted, but even after adjustment, there was a very strong obesity paradox shown, again, 15 years ago. Greg Foneroy assessed this in hospitalized patients of 110 decompensated heart failure patients. The higher BMI was associated with lower in-hospital mortality. For every 5-unit increase in BMI, heart failure mortality was 10% lower. And then in a subsequent paper in the Journal of Cardiac Failure, he used this data bank to show that this was the case in both heart failure with ejection fractions above 40%, as well as in those with heart failure with ejection fractions less than 40%. We did this meta-analysis of 6 studies several years ago. Interestingly, Chris O'Connor, the long-term editor of JACC Heart Failure, told me that, and actually, I actually published the first state-of-the-art in JACC Heart Failure right after Eugene Brunwald's state-of-the-art in the second issue of JACC Heart Failure, and became the second highest cited paper in the history of JACC Heart Failure, right behind Eugene Brunwald's state-of-the-art. And despite that, when we submitted this paper, they rejected it without sending it for review. And Chris O'Connor told me they keep track of this, that it became the highest cited paper that they had rejected from JACC Heart Failure. And basically, we showed, again, this obesity paradox, but for total mortality and cardiovascular mortality, not for rehospitalizations. Rehospitalizations went up with more significant obesity. And a few years ago, we published the same thing in heart failure with preserved ejection fraction, Salvador Caboni and I in the International Journal of Obesity. Now, many of you know that for many decades, since Donna Mancini's classic work decades ago, people have used the peak VO2 to predict prognosis in heart failure. And several decades ago, this was being heavily used to stratify patients to heart transplantation. We thought, and actually, this is a paper by Ahmed Osman 2 decades ago in the JACC. He's now an electrophysiologist in Florida. But my colleagues, Mandeep Mehra and Richard Milani, really thought that if you corrected the peak VO2 for lean body weight instead of total body weight, that it would be a better predictor than the 14 cc's of oxygen per kilogram per minute cut point used against total body weight. And that's because, although we now know that the fat cells are a very important endocrine organ, they don't have high metabolism or high perfusion. And when we did this paper in JACC, we showed exactly that the lean adjusted peak VO2 was a much better predictor of survival than was the total peak VO2 corrected for total body mass. But when we did this, we had to have percent body fat to get the lean adjusted. And when we first collected this data, the fellow brought to me the data that showed that the people who died had a lower BMI and a lower percent body fat. And right when I saw this, I immediately thought he probably had reversed the column. So go back and check it again. And of course, it was exactly right. And so we did a paper on this years ago, and this paper got rejected many times, got rejected about 7 times before it was finally accepted as a brief report in the American Journal of Cardiology. And this paper has now been cited nearly 600 times, where we showed a very strong obesity paradox for BMI and for percent body fat. When we showed that the patients with the highest BMIs and higher percent body fat had better survival than those in the lowest quintile of percent body fat and BMI. Now, you might say, okay, this might represent a cardiac cachexia. Maybe the lowest BMIs and lowest percent body fat patients were very cachectic. Well, this study was done in New Orleans, Louisiana. We don't have many homeless that are cachectic in New Orleans. In fact, the BMIs and percent body fats in our lowest quintile were in the low 20s, so hardly cachectic. But we showed in this paper that for every 1% higher percent body fat, there was a 13% reduction in mortality. Now, some people think this may be because the heart failure patients are losing weight after they develop heart failure. This was assessed several years ago in JACC from the ARIC study, where they had 1,500 patients in ARIC, where the BMI was measured 6 months or more, an average 4 years before the heart failure developed. And mortality was assessed over 10 years. And heart failure has a bad prognosis. 43% died during this 10-year follow-up. But pre-heart failure overweight and obesity was associated with 28% and 30% respectively lower mortality compared to the normal BMI. So they concluded in this JACC paper that being overweight or obese before heart failure developed actually predicted better survival after heart failure. So what are the reasons for this? We know that advanced heart failure, at least the catabolic state, there may be more metabolic reserve with greater obesity. Adipose tissue produces TNF alpha receptors that may neutralize TNF alpha. This could be potentially beneficial. We know that obese have lower atrial natriuretic peptides and plasmarenin activity. And so that may mean that the obese patient may present earlier. They also have more restricted lung disease, making them get dyspneic with less heart failure. They have higher blood pressures. So maybe they are tolerating higher doses of our cardioprotective medications. The mechanism is not clearly known. We also assessed the obesity paradox in this review several years ago for other things other than heart failure. And we've published data in our coronary population. This is a study from our cardiac rehabilitation population, published a decade ago, of 581 patients in cardiac rehab, where we assessed obesity by both BMI. We defined low BMI as less than 25, and we defined low body fat as less than 25% in men and less than 35% in women. And we showed in this paper that both having a low BMI and a low percent body fat were associated with 3.5-fold higher mortality rates. But almost all of the excess mortality, 4.5-fold times higher mortality, was seen in those who had both a low BMI and a low percent body fat. Again, both were independent. And then the next year in JACC, we assessed not only percent body fat in 570 coronary patients followed for 3 years, we also assessed lean mass. Now, really, what we really were assessing was non-fat mass, because we used percent body fat and we counted anything that wasn't fat as lean mass. And actually, this is both mostly muscle, but it's also the skeleton as well that makes up the non-fat mass. And we showed in this paper that having a low percent body fat was associated with a 2.6-fold increased mortality, but having a low lean mass or a non-fat mass was associated with a 3.1-fold increased mortality. The best survival were those who had both a higher percent body fat and a higher lean mass. And those who had the worst survival, this is 7 times worse survival, with those who both had a low percent body fat and a low lean mass. And if you had one of the two, you had an intermediate 3-year survival. So it makes sense that that low lean mass would be associated with worse survival, because lean mass is mostly muscle. And so this would certainly be protective. But the reason for the protection associated with higher body fat is not totally clear. Now, many studies that have assessed this have not assessed physical activity and fitness. This was assessed by Von Barry and colleagues in a paper in my journal in my first issue of Progress in Cardiovascular Disease. They evaluated 10 studies. This is all primary prevention that were prospective and objectively measured both fitness on the treadmill and BMI and jointly assessed their impact on all-cause mortality. They showed that compared with the non-obese, the normal weight fit, the unfit. Unfit was usually defined as the bottom quintile of fitness. In a couple of studies, it was the bottom quartile, and a couple it was the bottom tertile. But the unfit had twice the all-cause mortality, regardless of their BMI. Whereas the overweight fit and the obese fit, meaning those who didn't fall in the bottom unfit category, had similar survival as the normal weight fit. So they concluded in this paper that fitness appeared to be more important than fatness or adiposity for long-term survival. We later assessed this in a coronary population from the Aerobic Center longitudinal study. We assessed 10,000 men, mean age 47 years, who were followed on average for 13 years. We had data on fitness. We defined low fitness as those in the bottom tertile of age and gender associated fitness. And we assessed their body composition with BMI, with percent body fat, and with waist circumference. And we showed in this paper, in the Mayo Clinic Proceedings a decade ago, that those who were in the relatively high fitness, meaning they didn't fall in the bottom tertile, they had a much better survival, and it didn't matter what their body composition was. Whereas those in the low fitness had a much higher mortality. This is all total mortality. But there was an obesity paradox, meaning that in the low fit, those who had the lowest BMI, lowest waist circumference, the lowest percent body fats had a higher mortality than those who were a little bit higher. For a couple of the parameters, it went up at the very high end of the scale. But all of them had an obesity paradox for the low body compositions. And this is for total mortality. And we showed basically the same exact thing in cardiovascular mortality. A couple of years ago, Ross Arena allowed me to use his cardiopulmonary stress testing data bank in a group of systolic heart failure patients. This is 2,066 patients with systolic heart failure. We defined low fit by the Donna Mancini cut point of 14 cc's of oxygen per kilogram per minute. We didn't have percent body fat on these patients to do lean adjusted peak VO2. And these patients were followed for 3 years. Now, I can say this, that we did not have any severe obese, and we only had a few moderate obese. So mostly the obese in this population were mildly obese. This is again a cardiopulmonary stress testing data bank. But we showed in this paper that those who had relatively high fitness, it wasn't super high fitness, it was above the 14 cc's of oxygen per kilogram per minute cut point. And I think many of you who do cardiopulmonary stress testing know that 14 cc's of oxygen per kilogram per minute is no super level of fitness, but this is the cut point that's been used in heart failure for many decades. That they had a quite good survival, and it didn't matter what they weighed. Whereas if they had a low fitness, falling below this 14 cc's of oxygen per kilogram per minute, they had much higher mortality, and there was a strong obesity paradox. The best survival was in the obese, followed by the overweight, and the worst survival was in the normal weight. We had already thrown out the underweight, who almost always have a worse survival. A few years ago, the Hunt study allowed us to use their data from Norway. We assessed 6,500 patients with coronary heart disease, followed on average for 12.5 years, and showed in this paper a very strong obesity paradox. Again, the obese had a better survival. But physical activity was a much stronger predictor of survival than was BMI. And an obesity paradox was only present in those who didn't meet their physical activity requirements, meaning 150 minutes per week of moderate physical activity. If they met their criteria, they had a very good survival, and it didn't matter what their BMI was. But if you had a low BMI and you didn't meet your physical activity requirements, that the lower BMI had a better survival than those. Had a worse survival than those with higher BMI. Again, a strong obesity paradox present in those with low physical activity. Likewise, in JACC a couple of years ago, we looked at changes in BMI and changes in physical activity in 3,300 patients followed for almost 16 years from the Hunt study in Norway. These are all coronary heart disease patients, and showed that changes in physical activity were a much stronger predictor of survival than with changes in weight. In fact, there was no group where weight loss was associated with a better survival. In fact, those who in the normal weight group who lost weight had a worse survival, whereas those in the normal weight group who gained weight had a better survival. But physical activity and changes in physical activity, maintaining or increasing physical activity over time was associated with better survival. So what all of these studies basically showed was that physical activity and fitness markedly altered the relationship between adiposity of fat and subsequent prognosis in patients with cardiovascular disease, at least in patients with heart failure and coronary heart disease. Atrial fibrillation. As with obesity, we know that atrial fibrillation is also epidemic. In New Orleans and Louisiana, we have a lot of alcohol use, and that's worsening atrial fibrillation. But obesity also seems to markedly increase the risk of atrial fibrillation, along with hypertension, coronary disease, and heart failure. But obesity appears to be a significant independent risk factor for atrial fibrillation. In a meta-analysis by Franz Messerli and colleagues in American Heart Journal 15 years ago of 125,000, obesity increased the prevalence of atrial fibrillation by almost 50%. But once again, once atrial fibrillation is established, BMI seems to be protective. In the AFFIRM study, it was an independent predictor of better survival. And when you looked at the combined endpoint of cardiovascular mortality and all-cause mortality, the overweight and obese with atrial fibrillation had a better survival than did the normal BMI. And again, the cumulative hazard, the highest was for the normal weight, followed by the overweight, and the best prognosis was the highest BMI. Now, there is data now showing that increasing fitness and weight loss in atrial fibrillation is associated with reduced recurrence of atrial fibrillation. But right now, I don't think there's any data on weight loss and atrial fibrillation associated with stroke or with all-cause survival. So what then can we say about weight loss in cardiovascular diseases? We know that obesity increases most of the cardiovascular risk factors and is associated with significant increases in almost every cardiovascular disease. However, as I've demonstrated, an obesity paradox has been shown over and over now in many studies across the world. Weight loss definitely improves all of these risk factors, but the impact of weight loss on major cardiovascular events remains quite controversial. Again, we know there's an obesity paradox. Some stringent diets have prolonged the QT and increased ventricular dysrhythmias. A number of pharmacologic agents have limited efficacy and considerable toxicity. This may not be the case with the GLP-1 agonists, the liraglutide, and particularly semaglutide, and there's other agents that are being studied for weight loss that appear to be very promising. They certainly have had benefits in improving survival at lower doses in diabetes, So it may be that they may do the same for obesity. Certainly, we know that there's two papers 2 decades ago in the New England Journal of Medicine. Both showed exactly that caloric restriction and exercise training was safe and was associated with 60% reductions in diabetes. We published data showing that our cardiac rehabilitation and exercise training program reduced metabolic syndrome by close to 40%. And some small studies have shown benefits in prognosis and coronary disease. We certainly know that in hypertension, weight loss reduces blood pressure and left ventricular hypertrophy, as well as, or probably better than, most of the classes of antihypertensive agents. In heart failure, weight loss has improved the LV mass. It's improved parameters of systolic and diastolic LV function. It's improved functional class. But really, there's very little data on prognosis, with the exception of bariatric surgery. There have been papers that bariatric surgery improves the risk factors, particularly in type 2 diabetes, and improves short and long-term mortality. It appears to be safe in small studies of coronary disease and heart failure. And in a paper in JACC several years ago, they showed that patients who had a previous hospitalization for heart failure, that the severe obese who then had bariatric surgery had reductions in their hospitalization compared to those who didn't have bariatric surgery. This is about the only data that there is in weight loss in heart failure and clinical events. In coronary disease, probably one of the best analyses was in the Mayo Clinic proceedings. I'm, again, cardiovascular section editor and associate editor for 15 years of this journal, but Quinn Pack published this meta-analysis in the proceedings 6 years ago. In 12 studies of 14 cohorts of over 35,000 patients, they actually showed that overall weight loss was associated with a 30% increase in major events in coronary heart disease patients. But presumed intentional weight loss, and this is presumed because this is cohorts that was in cardiac rehab where they were exercising and they were, recommending diet, and they were recommending the overweight and obese patients to lose weight. This was associated with a 33% reduction in subsequent risk, whereas just the observational weight loss in 10 cohorts was associated with a 62% increase in events. Again, this is probably the best we have because there's very little randomized data on prognosis, and people have talked about doing major studies on this, but so far none of these have gotten off the ground. And in heart failure, over the years, some of the societies have recommended weight loss for heart failure only in the more significant obese. In more recent heart failure guidelines, they really don't make any strong recommendations for weight loss other than saying that the severe BMIs over 40 are associated with a quite bad prognosis. Certainly, there's been vastly different cut points, really due to minimal data to make these recommendations. And clearly, further research is needed to determine ideal body mass index and body composition in cardiovascular disease, including systolic and diastolic heart failure. We certainly know from epidemiologic data, though, that maintaining a lean weight throughout the lifespan is associated with much less cardiovascular disease and certainly much less heart failure. And obesity, adipose tissue distribution also seems to matter. Probably worsens to have more visceral adiposity, more liver adiposity, more pericardial fat than it is. Subcutaneous fat, on the other hand, may not be aesthetically pleasing, but it seems to be associated with a better prognosis. Certainly, skeletal muscle is very important and may improve heart failure prognosis. And so muscling up, increasing muscle mass is associated with better prognosis in heart failure. So muscle also increases the BMI. And so again, BMI is both fat and muscle. And so the muscle component certainly should be beneficial. And we've recently reviewed all of the data in a state-of-the-art paper in the Journal of Cardiopulmonary Rehabilitation Prevention. Right now, this paper, I've been told, it's been the leading cited paper of the year for JCRP. And we're talking about the importance of muscular mass and muscle strength in many different types of patients with cardiovascular disease, as Salvatore Carboni is first author. And body composition also seems to matter in advanced heart failure for sure. And heart transplantation, for example, obesity is associated with more heart transplantation complications, including wound healing, infections, pulmonary complications, more DVT, pulmonary embolism. It's associated with more early high-grade acute rejections and higher 5-year mortality. Typically, class 3 obesity especially has high complications. And generally over the years, I think this is broken from time to time, but generally there's been no listing for heart transplantation with class 2, that's BMI 35 and higher. Lvad, obesity is associated with more driveline infections, but overall similar outcomes. Obesity with BMI greater than 35 is associated with higher device-related complications, leading to higher heart transplantation classifications and earlier transplantation. Obesity with Lvad, who went on to heart transplant, had worse outcomes. And weight loss strategies are needed in these patients. And one of our former fellows, who's now with you at Yale, Adrian da Silva de Abreu, published about 6 or 7 papers on this in various formats. The biggest one was in the Journal of Cardiac Failure, discussing the potential benefits of bariatric surgery in patients with Lvad, particularly the sleeve procedure that is getting people to lose weight, improve their exercise tolerance, and be better candidates for heart transplantation. Now, we're still in the COVID era, and there certainly does not appear to be an obesity paradox in COVID. We talked about this early in COVID when an epidemic and a pandemic are colliding. It's leading to a bad outcome. And this is a paper quote from William Wordsworth that Valentin Fuster had in Jack in 2020. Let us learn from the past, the profit in the present, and from the present to live better in the future. We know that there are a number of bad things with obesity that have worsened COVID. There's more cardiometabolic disease, all that is associated with worse prognosis. Inflammation. It's the inflammation that really worsens the prognosis in COVID, and the obese already have high levels of inflammation. They already have a hypercoagulable state, and there's many thrombotic complications in COVID. The obese also have more immune dysfunction. They have already altered pulmonary function that puts them at bigger risk when they have respiratory complications, and they need to potentially go on ventilations. They have way more heart failure with preserved ejection fraction and atrial fibrillation. Both are associated with worse prognosis in COVID. Now, many people don't recognize that obese have way more kidney disease, lower GFRs, more proteinuria. Early on in COVID, people were worried about running out of ventilators. We actually came closer to running out of dialysis machines than we did with ventilators. There's also more endothelial dysfunction, and the COVID coronavirus attacks the endothelium throughout the body. One of the biggest things I think that when I was writing this state of the art that I learned was that the adipose tissue, the fat cells, have actually more H2 receptor. That's the spot where the coronavirus enters the cell, that they have more H2 than actually does the lung tissue. So the adipose tissue in the obese is serving as a reservoir for the COVID virus. We did a meta-analysis very early in COVID of 13 studies showing that the obese had a 39% higher severe COVID with more mechanical ventilation, more ICU stays, and more deaths. And other studies have mostly shown the same thing. Some studies are showing that if you correct for all of the bad things that obesity does on diabetes and atrial fib and heart failure and coronary disease and cardiac heart failure, that you may lose the effect of obesity as an independent risk factor, but certainly it appears to be associated with much worse prognosis. Likewise, fitness also appears to be very protective in COVID. This is a paper, it was a small paper, of 246 patients in the Mayo Clinic proceedings from Detroit hospital, that patients who had the fitness measured well before COVID, that fitness predicted hospitalization during COVID, that for every one met higher exercise capacity, there's actually a 15% reduction in the risk of hospitalization with COVID. And if you corrected for other factors, it was 13% reduction in hospitalization with COVID. One of my good friends, Bob Salas, in Kaiser in California, published a paper in the British Journal of Sports Medicine, which is the most prestigious sports journal in the world, showing that in their very large study from Kaiser, that those who met their physical activity requirements had a much better prognosis in COVID, less hospitalizations, less ICU stays, and lower mortality. So physical activity and fitness seem to be very protective against COVID. And we published the editorial for this Mayo Clinic proceedings paper where we said, fit is it in COVID-19, future pandemics, and overall healthy living. We particularly in this paper talked about the high risk of the African-American population. And we've published papers decades ago showing that the African-American population not only have higher obesity, but they have lower fitness. And even with randomized studies of exercise training, they're getting lower improvements in their exercise capacity, something that really needs to be addressed in the future in the African-American population. So in summary and conclusion, I think now there's overwhelming evidence that supports the importance of obesity in the pathogenesis and progression of most cardiovascular disease. And this is probably particularly heart failure and atrial fibrillation. But I think we have to recognize that an obesity paradox exists. If I'm sitting with the patient with a BMI, just had a heart attack, or just developed heart failure of 22, compared to one in the next room with 32, 2 or 3 decades ago, I would have thought that the lower BMI would have a better prognosis, and that's just the opposite. And many data are showing this. Maybe the patient with the lower BMI doesn't develop the coronary disease and the heart failure as often, but once they develop it, they have a worse prognosis. I think at present, there's very little supporting purposeful weight reduction, but substantial on increasing physical activity and exercise training, especially that increases cardiorespiratory fitness. And along with this, there's certainly some weight loss as well. I certainly think we have to recognize that if the current obesity epidemic continues, and particularly if it worsens, as I'm very afraid that it will, because the scary thing is the obesity in the adolescents and children. This was unheard of. I'm 63 now. We didn't have hardly any obesity in the kids when I was growing up. When my own kids were kids, they had a little bit higher obesity. And now there's a pretty significant amount of kids that are in grade school and high school that are already quite overweight. I think there's many reasons for this. It's the not being outside playing the whole day, not getting the physical activity. It's the fast food. It's being on the computer and on their cell phones, way too many hours per day. But this is certainly a scary trend that I think could unfortunately end the steady increase in life expectancy that's been occurring in recent decades. In conclusion, I think both fitness and fatness are very important. In a perfect world, I think sometimes when people hear my lecture, they think I'm saying it's good to be heavier. And that's not what I said. Please don't say that I said that. But in a perfect world, everyone would remain lean and fit throughout the lifespan from childhood to old age. But this is hardly the case in our present society, where most gain weight and lose fitness over time. It would be better to gain some weight and maintain fitness than vice versa, because I think the majority of data supports that fitness and physical activity is considerably more important than adiposity and fatness for long-term health and cardiovascular health. And this is something that I think we all in cardiology and probably in general medicine here on a frequent basis. Give it to me straight, doc. How long do I have to ignore your advice? And reason that most people give why they're not exercising is that they're way too busy. Their schedule doesn't allow it. But I think this is the answer, what fits your schedule better. Exercising so many minutes per day. I used to have 30 minutes. I used to have an hour. I don't know what the time is now because we've published papers. I didn't go over these today, but we've published papers showing very significant effects of, say, running at just 10 minutes a day, producing what appears to be maximal cardiovascular and all-cause survival benefits. But again, getting some exercise is certainly protective, and getting no physical activity and exercise is associated with worse prognosis and survival. Again, thank you very much for the invitation to speak here this morning. I hope you all have a great rest of the day. Thank you very much.
Thanks for the great talk. I'm gonna sort of give a couple minutes to, we have like 5-7 minutes for questions. I have one question in the chat already from Dr. Furman. The question is, can you comment on your thoughts about elevated CRP, even to the 6 to 10 ranges among patients with obesity?
Yeah, so C-reactive protein is increased in obesity. And again, many other things are increased with obesity. So there's higher triglycerides, there's lower HDL, there's higher sugars, there's higher blood pressure, all of which you'd expect lower fitness in general, all of which you'd expect would certainly worsen prognosis, not only in heart failure, but also in coronary heart disease. This might be a reason that the obese develop more cardiovascular disease, but even despite this, they appear to have a better prognosis. We did publish a paper on the combined effects of adiposity and inflammation in the International Journal of Obesity several years ago. I'd be happy to send this to anyone who's interested. But again, I think that despite the increased inflammation is probably playing a very bad role in COVID among the obese, but it's probably leading to more development of cardiovascular disease along with the cardiometabolic abnormalities. But again, this does not negate the obesity paradox occurring in these same patients with atrial fibrillation, hypertension, and heart failure and hypertension, for example.
Rohan, maybe I can ask my question.
Yeah.
It's Eric Velasquez. Chip, thank you
Yeah.
so much for a wonderful review. And I've been following this story over decades now, and we have so much more still to learn. I guess the question I would ask you is, in your focus on this in this area, have you found any evidence to suggest, or do you have any mechanisms that you think could be active around the interaction effect of obesity or weight and the effect of guideline-directed medical therapies? So, are different therapies more or less effective based on someone's weight, particularly in heart failure?
Yeah. So I think one thing that is hard to correct for, but I actually, seen this in the paper, and I think that this would be pretty obvious to clinicians. But if you look at a heart failure data bank, that the obese patients are taking higher percentage of the cardioprotective medications, but probably what's not always included in the data bank, but a couple of papers have included some information about dosing, that the doses tend to be higher in the obese. So, in past years, the obese were taking maybe higher doses of ACE inhibitors and ARB, higher doses of the beta blocker. Maybe now they're taking higher doses of Entresto. Maybe they're more likely to be on the SGLT2 inhibitor. All of things that could be protecting them against heart failure. They have more diabetes, so they're going to maybe more likely to be on an SGLT2 inhibitor. Although I think we have pretty good data right now that the SGLT2 inhibitors are helping the non-diabetic as much as they are the diabetic with heart failure. But I think all of these things could be factors. Certainly in advanced heart failure, when you start getting to class 3 and 4, that's where you start having the cardiac cachexia component, and having some increased weight could be a better reserve. I don't think this would really have much factor, though, in why would that be helpful in class 1 and 2 obesity, and certainly why would that be helpful after somebody comes in with a piece, a small non-ST segment elevation MI and gets a PCI and goes home the next day, or even sometimes that day now, but certainly they go home within a day or two. Why would that, in that case, would the excess fat be protective? We do know, though, that as you gain weight, you do gain muscle. Mostly when adults gain weight, they mostly gain fat, but they always gain a little bit muscle along with the fat. They gain more muscle, of course, if they were doing exercise, and vice versa. When you lose weight, you obviously lose fat, but you lose muscle too. The only way you can prevent losing the muscle is if you're doing a bunch of resistance training. But so that may be part of the increased muscle could be part of the protection for the heavier patient with cardiovascular disease. But again, some of the mechanisms are certainly not clear, despite people analyzing this over the last 2 decades.
Dr. Spatz had a question.
Yeah, thank you so much for a terrific talk. And I think you just kind of referred to this in your last answer. But when I did my training at Montefiore at Albert Einstein, and I know a lot of people on the call were also trained there, what the former chair of medicine who passed away this year, Phil Leaf, would always pound into us just how strong people with obesity are, just by negotiating their daily lives, that their resistance training, which is something that we often don't measure as part of physical fitness, was very high, and not to underestimate underestimate the prognosis. Estimate the prognosis of people with obesity, because in fact they are pretty physically fit. Are there better ways to measure that, and how do we factor that into our risk equations for people?
Yeah, so certainly, I think there are studies that, in heart failure, for example, that have measured thigh circumference and forearm circumference, the biceps circumference, that's a marker of muscular strength. Certainly, you can do a test of muscular strength, hand grip strength analyses. But I mean, I think that's partly the case is that if someone takes a 20-pound pack and puts them on their back and carries it around all day long, and they're doing that for years, they're going to be gaining a little muscle because they're doing more work when they're walking around, climbing the stairs. And that's not exactly the same as the weight that the obese is carrying. But carrying the weight does increase the muscle mass. And the vice versa is true, that in the underweight, or even in the low ends of the normal weight. I think kind of the normal weight in the U.S. now is probably no longer, BMIs of 19. I think BMIs of 19, 20, 21 are pretty low weights, and, compared. So in many of our underweight, if they particularly, some of them have decent amounts of body fat, but often they have very little muscle, and they are maybe a thin, weak population, and you flip that, compare them to the heavier, more muscular, at least overweight or mildly obese. I think it's always going to be bad to develop severe obesity. There are some of the obesity paradox papers, though, that show that the early prognosis can even be better sometimes in the class 3 obesity. Certainly, that's not the case long term. In the long-term studies, whereas the mild obese generally continue to have a better long-term prognosis against cardiovascular disease, and I think part of it is the muscle component.
We've had a few
muted,
more questions.
bro. Okay.
Yeah, we've had a few more questions in the chat. I'm going to try and summarize them so we can keep the conversation going. There's a low BMI, high CVD seems to be a different model compared to high BMI, high CVD. What are the risk factors of low BMI cardiovascular disease risk compared with the latter? Yeah. And then there's a question about the type of diet and weight loss. Weight loss you mentioned is may not have cardiovascular beneficial effects if the type of diet plays a role.
Yeah. So the first thing is that it may be that, for example, in at least in coronary disease, it may be that the part of the obesity clearly increases all the cardiometabolic risk factors, increases inflammation, probably increases the prevalence to develop coronary heart disease. But the thin patient who develops coronary heart disease despite maintaining leanness throughout their lifespan, despite the fact that they have a lower blood pressure, less CRP, less cardiometabolic disease, less diabetes, less triglycerides, higher HDL, they probably develop their coronary disease because of genetic predisposition. Whereas the person who gained weight over many decades developed the coronary disease from a different reason because of all the cardiometabolic abnormalities that they developed that led to increased atherosclerosis. So this makes those patients different, and this might mean differences for the prognosis. Regarding diet, I think that there's been many studies that argue one diet's better than the other. I think probably the most healthy diet is probably plant-based diet, Mediterranean diets with more seafood, the diets maybe that have more good fats like monounsaturated fats, like the fats in olive oil and fish oils seem to be probably beneficial. But probably also that in the patients who have obesity and who have higher sugars, higher triglycerides, lower HDL, probably having a diet that's not only lower in calories, but lower in sweets and carbohydrates is probably a more preferential diet. But I do think that if one could combine diet with physical activity and resistance training, this would go a long way to improve prognosis, not only to reduce cardiovascular disease, but would improve the prognosis of our patients with known cardiovascular disease. We know this in cardiac rehab for coronary heart disease. There is some data, at least from Heart Failure Action, which is why heart failure with reduced ejection fraction has an indication for cardiac rehabilitation. But again, there's very little data on weight loss outside of the exercise training studies that has indicated improvements in prognosis. I think most of us believe that if you did this and it was purposeful, it would be associated with better prognosis. But the problem is that the data that we have in the literature is observational weight loss that's generally associated with a worse prognosis. And so unless we did large randomized trials, it's hard to more vigorously recommend weight loss, at least for the overweight and for the slightly obese. I think for those patients, we should be more recommending exercise training and physical activity to improve their fitness and muscular strength. Whereas, again, I think for the very severe obese, that's a different story. I mean, I think that once the BMI is in the 40s and 50s, I mean, that's associated with a pretty terrible prognosis. And I think it's almost everyone, without doing a randomized study, everyone knows that purposeful weight loss in those patients is going to be improving their prognosis.
Perfect. Thank you. I think you also sort of answered another question about randomized trials that sort of came up in the chat. Thanks again for taking the time to talk to us this morning and presenting a pretty comprehensive overview of literature in this important domain. And we look forward to welcoming you in person in the future. Thank you.
Okay, thanks, Rohan. It was a pleasure to be here, and saying hello to my old fella Adrian if he's still on the line. Have a great day, everyone.